Hello, 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 and welcome to Nursing News You Can Use at 5. I'm Tina Baxter, your host, and thank you for tuning in. Thanks to all of you that are joining us on our YouTube channel, the Nurse Shark Academy, and those who are joining us on our Facebook pages, Baxter Professional Services and the Nurse Shark. Thank you for tuning in. Today is Wednesday, November the 27th, 2024. And first of all, I want to say happy Thanksgiving to everyone. I hope you have a great day tomorrow. But let's get into our affirmation for today. Happiness is an inside job. I choose thoughts that make me feel supported and loved. I'm going to say that again. Happiness is an inside job. I choose thoughts that make me feel supported and loved. And that's from the Louise Hay calendar for 2024. Let's get into the news because there is a lot to cover. So hold on to your hats for this one because there's a lot that we're going to talk about today. All right. So our first story coming up is from the Dayton Daily News. And it says, what's the cost of a human life? Nurses urge lawmakers to support staffing ratio bill. Proper staffing is more than a logistical goal. It is a matter of life and death for our patients and the professional sustainability of the nurses who care for them, said Catherine Henderson, a nurse with 11 years of experience. The proposed legislation would set staffing ratios depending on the hospital setting, ranging from 1 patient per nurse up to 6 patients per nurse, according to the bill's analysis. Hospital systems that oppose the legislation often reference costs, and one legislator got right to the point. Ohio Representative Darnell Brewer, Democrat from Cleveland, says, I represent the Cleveland area with one of the largest hospital systems in Ohio. They came to me about this bill. What do you say to them when they tell me that as a legislator that this bill would increase costs? I would like to say to them, or have you say to them, what's the cost of a human life? What cost is safe staffing? Said Tony Sopko, president and chairman of the UAW Local 2213 Professional Registered Nurses out of Toledo. Those who testified repeatedly emphasized that staffing ratios are about more than the nurse's mental and physical well-being. It is also about the patient's well-being. Exposure to shifts with high levels of registered nurses had lower odds of mortality by 8.7%, according to one longitudinal study published in the International Journal of Nursing Studies. Low staffing was associated with higher odds of mortality by 10%, according to that same study. The associations between mortality and staffing by other groups were less clear. In 2023, nurses submitted more than 2,600 assignment despite objection reports to the Ohio Nurses Association, documenting unsafe conditions in the hospitals, with the majority dealing with what they saw as inadequate staffing, said Rick Lucas, a critical care nurse, as well as president and executive director of the Ohio Nurses Association. Minimal staffing standards reduce complications, improve patient satisfaction, and decrease readmissions, Lucas said. These all cut costs for hospitals in the right way. Family members of Tristan Kate Smith, a Dayton nurse who died by suicide in August 7th of 2023, also talked before the House Health Provider Services Committee, reading a letter Tristan had written about the strain the nursing profession had had on her. Her father, Ron Smith, found the letter on her laptop after her death. From a young age, Tristan always wanted to take care of people, said Ron Smith of Oakwood. She fulfilled that dream, a dream that ended up taking her life. Nurses are burnt out, and it has an effect on patient care, Ron Smith said. So for those of you that haven't kept up to date, this is referencing the letter that we talked about previously on the show when it was first announced, unfortunately, by her death. She wrote a letter called A Letter to My Abuser. And that is what they are referencing here. So this is a continuation of the legacy that she's leaving for us. And then Ohio, this bill is going forward. So if you are nurses in Ohio, this is a good time to call your legislator and say, hey, listen, I need you to support this bill because it's not only for nurses' well-being, but it's for patient safety. And there's a lot more to this article. So I'm going to encourage you to head on over to Dayton Daily News to get more information about this because we just don't have the time to delve into this. But if you're in Ohio, I'm going to suggest that you contact your state legislator and talk about House Bill 285 because I guarantee you more than likely your hospital is opposing it. So you need to make your voices heard. So why don't we just flood their phone lines and emails and just let them know, hey, let's support this important bill. All right, so let's move on to our next story. Um, this story came from KFF Health News. And I just found this interesting because we were talking about hospitals, and we're going to get to a really big story a little bit later um, that came from Bloomberg, because everybody's been talking about it. They've been asking me, have you heard about this? So it's a series of articles. We'll get into it in a moment. But I want to talk about how healthcare, we've talked about it on the show before, how healthcare is funded. And so this is a story that they reported that a toddler got a nasal swab test but left the emergency room before seeing the doctor, and they were still billed $445. So it says Ryan Wetstein Newman was inconsolable one evening last December. After being put down for bed, the 3-year-old from Peoria, Illinois, just kept crying and crying and crying, and nothing would calm her down. Her mother, Maggie Wetstein, remembered fearing it could be a yeast or urinary tract infection, something they've been dealing with during potty training. The urgent care centers around them were closed for the night, so at 10:30, she decided to take Ryan to the ER. The ER wasn't very busy when they arrived at 10:48. Wetstein, recalled. Medical records indicate that they checked in, and she explained Ryan's symptoms, including the intermittent fever. The toddler was triaged and given a nasal swab test to check her for COVID-19 and influenza A and B. Wetstein said they sat down and waited to be called, and they waited. As Wetstein watched Ryan in the waiting room's play area, she noticed her daughter had stopped crying. In fact, she seemed fine. So she decided to drive home. Ryan had preschool the next day and figured there was no point in keeping her awake for who knew how much longer and getting stuck with a big ER bill. There was no one at the check-in desk to inform that they were leaving, she said, so they just headed home to bed. Child went to preschool the next day. She forgot all about the ER visit for about 8 months, and then the bill came. At $444 for a combined COVID flu test from an ER visit in which the patient never made it beyond the waiting room. So even though Ryan and her mother had left without seeing a doctor, the family ended up owing $298.15 after the insurance discount. At first, she said she couldn't recall Ryan being tested at all. It wasn't until she received the bill and requested her daughter's medical records that she learned the results. Ryan, fortunately, had tested negative for both COVID and both types of flu. While Wetstein said the bill isn't going to break the bank, it seemed higher to her, considering Walgreens sell at-home COVID and flu combination tests for $30 and can do a higher quality PCR testing for $145. Under the public health emergency declared in 2020 for the COVID pandemic, insurance companies were required to pay for COVID tests without co-payments or cost sharing for patients. That requirement ended when the emergency declaration ended in May of 2023. So she had to pay her co-pay. So this is what's interesting. Again, Medicare and other insurance will often pay for the regular testing. So the exception being when the test is performed by the hospital laboratory, which is often what happens during ER visits. So Medicare pays $142.63, the joint test which Ryan received, but the family is on the hook for more than twice that amount, and the initial hospital charge was over 3 times as much. So the hospital is, quote, utilizing their market power to make as much money as possible, and the insurance companies are not at all that good at pushing back. A markup of a few $100s is a drop in the bucket for big insurers, but for patients who get unexpected bills, it can be a big burden. So there are some things that happen. Wetstein knew she could just pay the bill and be done with it, but the fact is I never saw a provider, and the fact that it was just for a COVID test is mind-blowing to me. She contacted the hospital's billing department to make sure the bill was correct. She explained what happened and that the hospital representative was also surprised by the size of the bill and sent it up for further review. She said, "I'll pay this till you hear from me." Soon she received a letter from the hospital explaining that the charge was correct and supported by documentation. So I'm wondering, what documentation? The documentation was for them to perform the lab test and for the lab personnel to read it and report the results. Once they thought she was avoiding any charges by taking Ryan home without being seen and said she got a bill that they had verified that I have to pay, like I said, it's mind-blowing to me. So ERs are the most expensive option for care in the nation's healthcare system, and the meter can start running as soon as you check in, even if you check out before receiving care. So this is important for people to know. If your issue isn't life-threatening, consider an urgent care center, which is often cheaper, and look for posted notices to confirm whether it's an actual urgent care center. The urgent care centers near Ryan's home were closed that evening, but some facilities stay open late or around the clock. So again, I keep saying Weinstein, it's Wetstein. So again, I just bring that up because people don't understand when they go into the emergency room, even if you're just checked in, there can be a bill associated with that. And is that right? I don't know. Let me know what you think. Okay, here's our next story. This is coming out of West Virginia, and it says West Virginia solicits company to manage its contract nurses, won't answer questions. So if you're in Virginia, West Virginia, you might want to consider, looking into this. If you have a business staffing facilities, this might be of interest to you. So the West Virginia Department of Health Facilities is seeking a single vendor to manage all of its contact labor services. The Department of Health Facilities, reliant on contract nurses to staff state-run hospitals, is now seeking a single vendor to manage all of its contact labor services. The changes follow a recent legislative audit that said that financial implications of relying on contract labor at significantly higher rate of pay was not sustainable for the state. Contract positions pay more than the state's own full-time nursing jobs. Which, okay, let me stop there and beg to differ. I understand if you need to pay to supplement your staffing, that is one thing. But why aren't you paying your full-time staff more money and keeping them? That's my question. But anyway, make it make sense, West Virginia. But okay, let's go on. Since 2015, the state has spent $284 million on contract positions in state-run facilities, including long-term and psychiatric care. The millions of dollars spent on contract nursing were paid out to 33 vendors over the last 9 years, 28 of those who were out-of-state vendors. So Evan Worrell, Republican from Cabell, said on Tuesday that he didn't believe the decision was connected to the audit, but questioned the timing of the Department of Health Facilities soliciting a new vendor as Governor Jim Justice administration winds down. I'm not sure this is the right approach because ultimately it won't save the state money. The timing of this is odd, a month and a half before Patrick Morrisey takes office. Let Governor-elect Morrisey make this decision. Okay. On November 18th, the DHF began soliciting bids for a vendor that would, quote, contract with the staffing agencies and provide support and guidance on contract staffing agent or broker for 7 facilities across the state. The bid window closes on December the 5th. So if you're looking to bid on this, you better get in on it because you only got a week left, roughly. A spokesman for the DHF didn't respond to multiple questions for this story, including how much the contract could cost the state. So there's no way of knowing. House Speaker Roger Hanshaw, Republican from Clay, said he supported the change to one vendor. I think the data would bear out consolidating into a single vendor with a solid track record of doing this and doing it well is the exact way to care for West Virginians. Lawmakers and educators have attempted to bolster the state's nursing programs, but shortages persist. The number of medical staff determines how many patients can be served. As of August of 2023, only 2 of the hospitals, William R. Sharp Jr. Hospital in Weston and Mitchell Bateman in Huntington, were operating at licensed bed capacity, according to the audit. So there's more to this story. Please head on over to and share this information with them. So this is from... I'll post this link in the chat if you want to check this out. But look at this story further. I'm just going to say, if you're in West Virginia, one, I'm just curious, why aren't you paying more for your staff nurses that they'll want to actually stay and work for you? That makes more sense to me. Okay, that's number one. And number two, I'm going to ask if you are a staffing agency and you want to bid on this, I'm just letting you know, hey, it's out there. So go for it. Okay, so here's our next story. This is from McKnight's Long-Term Care News. And it says CMS obesity drug coverage implications for nursing home patients. So I don't know. I'm just going to say, share this story. I don't know about you, having worked in long term care for a long time, we have seen the increase in patients who are obese. And I'm not talking about like a few pounds overweight. I'm talking about bariatric patients that we have to have specialized beds, we have to have specialized lift agents and things like that. And so we've seen an increase in that. Okay. And so there are some patients that we have, some residents that would love to be able to lose the weight so that they can get out of bed and be able to walk and do the things on their own. So this has implications for those residents as well as for the safety of the staff and for better quality of life for the individuals that are affected by this. But let's get into it. So, a new rule proposed by the Centers for Medicare and Medicaid Programs on Tuesday offers possible alterations to the Medicare program, including an expansion of coverage for anti obesity medications. The contract year 2026 MA and Part D rule aims to increase care quality, CMS said, and part of its targets severely overweight individuals by permitting coverage of anti obesity medications for the treatment of obesity, quote, when such drugs are indicated to reduce excess body weight and maintain weight reduction long term for individuals with obesity. If CMS rule is finalized, it could introduce hope for at-risk patients and relief for providers caring for the population that accounts for a quarter of all nursing home residents. Obese skilled nursing residents often account for higher facility costs due to increased staffing needs and equipment expenses, a study by the Gerontological Society of America recently found. For a handful of residents who have obesity as a diagnosis without type 2 diabetes or with prediabetes, it opens access to these medications and in that way would be a care improvement. Chad Warts, CEO of the American Society of Consultant Pharmacists, told McKnight's Long-Term Care News Tuesday. CMS administrators emphasized the seriousness of obesity on a conference call Tuesday. So there are a lot of implications for this. It would be great because I have taken care of some residents that really could have benefited from this. And in fact, there's a young lady that I think her life might have been saved if she could have had her weight managed better. I mean, it was very difficult to do. Obviously, she was complicit in some of those things, ordering, eating things that she should not eat. But I want to say it would be helpful if we had something else to add to our toolbox to assist. So, in April, CMS issued a decision to cover some popular weight loss drugs that could help chronically overweight patients shed pounds. Many experts were in favor of the rule, noting obesity to be the foundational factor in diminished health and well-being. However, it says currently Part D plans do not cover anti-obesity medications, specifically for the use for weight loss or weight management. These prescriptions are covered only when used to treat other ailments such as type 2 diabetes. While the rule will expand weight loss medications' reach, experts caution that it could also increase costs as an important factor to consider, as Medicare payments are a well-documented point of contention for many providers. This mandate could increase medication costs to Medicare and Medicaid and reinforce these medications as targets for the negotiation list under the Inflation Reduction Act. This should be weighed against the benefits of the weight loss to the overall healthcare costs and quality of life improvements, report says. 22% of Medicare beneficiaries were diagnosed with diabetes in 2022. Brooke LaSure said during the call, that's twice as many as 10 years earlier. So again, these medications may have a role in this. We'll see how this plays out. But if you want to hear more about this, head on over to McKnight's Long-Term Care News, and you can follow this story as well. Okay, we're going to take a brief break, and then we're going to come back for our next story. All right, let's have our next story. This is coming out of the UK, and I thought this was kind of interesting. I think this is from the BBC. Yeah, it's from the BBC. And I want to shed light. I often share stories from around the world because, one, the nurses are around the world and they're working. But I want people to understand, particularly in the U.S., that this isn't just an isolated incident to what's happening in the U.S. This is happening in other places. And so we need to talk about this. And I'm talking about violence in healthcare. So this a particular article says, "Give me prescription or I'll kill you," nurse told. Staff at GP surgery were left in tears and forced to call police after incidents in which angry patients threatened them and acted violently. Nurse consultant Dr. Jennifer Loke, who works at the practice in East Yorkshire, said she was forced to press a panic button when one patient started moving towards her, saying, "If you don't give me that prescription, I'm going to kill you. Unalive you." Hummersburg Police has received 411 reports. That's, I guess they're equivalent to 911 reports of abuse toward GP staff in the region since 2019. Although most were verbal, the force investigated assault, a kidnapping, and 6 unaliving threats. Sorry, I know this is YouTube. So the British Medical Association said it knew current pressures could make it harder for patients to get care, but no one should go to work fearing abuse. So again, this is something that we've seen in the U.S., we're seeing in other places. This is a big problem, and we need to talk about it. Tom Park Polson, a practice administrator, said that the vast majority of abuse come from patients was over the phone and usually triggered if an appointment or prescription could not be given immediately. One patient who had not received an immediate appointment said he would come down to surgery and sort us out. Another broke a door by slamming it in a rage. Occasionally, staff have been threatened in person and called police to remove patients from the building, including the time when one refused to leave until a doctor came to see them there and then. We have had patients to try to physically intimidate staff. We've had an incident of a team member being shoved in one of the clinical rooms. Some colleagues have been brought to tears. The police figures include 19 occasions where staff were assaulted and injured. Officers were also involved in 2 reports of stalking, a kidnapping, and 6 threats to unalive the person. Among the threats was one made toward Dr. Loke, an academic doctor who worked as a nurse consultant. And so there were threats of unaliving her as well. Police contacted her to say that a former patient had said they wanted to unalive her. A restraining order had been put in place. Dr. Loke says she was not frightened by the incident, but abuse took its toll. She says it's stressful enough to work in a surgery when you have to cope with a lot of complex issues and you need to maintain your cool with patients who are anxious and depressed. And yet you have all this in the background, so it's quite distressing. Most of the patients she saw were good, but attitudes had changed because of an on-demand and consumer culture. Patients think that they are customers with rights. They think they can just call the GP surgery and get antibiotics in the same way that they go to McDonald's and order an ice cream. Dr. Loke said general practice was becoming a less attractive place for people to work. She feared the issue could start to affect staffing levels and called on patients, quote, to modify their behavior for general practice to survive. Brian McGregor, who chairs the BMA's Yorkshire Regional Council, described the police figures as disappointing and concerning. Even one incident of abuse against GPs and their teams is unacceptable. The current pressures and lack of staff can make it harder for our patients to get the care that they need, but people must not take out their frustrations with the system on GPs and their staff, people who are just doing their best in difficult circumstances. So if you want to hear more about this, head on over to the BBC. But again, I'm saying that this is just not an isolated incident that happens in the U.S. It happens elsewhere. And I think it's important that we recognize this. And so it's a continued problem. All right, let's come on home then to good old Indiana. I have another story. It says Indiana hospitals pull merger application after pushback over monopoly concerns. This is from KFF Health News. It says 2 rival hospitals in Terre Haute, Indiana, pulled back their merger application Monday, just days before the state was due to rule on the deal amid growing backlash to such medical monopolies. The proposed merger between Union Health and Terre Haute Regional Hospital, the only acute care hospitals in Vigo County, would have left Terre Haute's 58,000 residents and those in surrounding region with a single hospital operator. Although federal laws prohibit monopolies, the hospital sought the merger under a state provision known as Certificate of Public Advantage Law, or COPA. Recognizing the COPA process is a very complex, innovative approach to improve access and quality of healthcare for area residents. We believe it is best to withdraw the current application, Union Health said in a statement on its website. Union said it plans to submit a new application after working with Indiana regulators to, quote, ensure the benefits such as improved access and quality are included. The withdrawal came 9 days before the December 4th deadline for state regulators to rule on whether to okay the merger. In recent months, the state health agency had received a deluge of public comments from residents, and the Federal Trade Commission opposed to the deal between Union Health, a nonprofit whose main hospital is licensed as a 341-bed facility, and the 278-bed Terre Haute Regional Hospital owned by for-profit chain HCA Healthcare. Now, okay, so I'm going to chime in here because this is definitely a commentary show. So, we've talked before about these mergers that happen when for-profit entities take over these nonprofit hospitals, and then a lot of times they sell the land out from underneath them, leasing it back to the hospitals. So the hospitals are ending up back in worse conditions than they were in. We've all talked about Steward Healthcare, so we already know that, so there are concerns there. So I'm kind of glad they pumped the brakes on this. This is something we probably need to keep an eye on. But if you're in that region, you might want to talk to the hospital officials and to your state legislator about this, because again, I just have some concerns creating these big hospital monopolies here. It's a big problem. It's a big concern, because then you cut down competition. Oftentimes, when a for-profit entity comes in, research has shown they depress the staffing ratios. Yeah. So what is going to be the cost to the community? If you have comments about it, let me know. All right. Okay, so this is another article. This came out of North Carolina this time. It's a scope of practice reform in North Carolina could improve health outcomes for patients. This is an opinion piece, by the way. I want to share this out. This is an opinion piece, but this is from this particular columnist, John Hood. So it says, the North Carolina General Assembly has made our state a more attractive place to live, work, and do business by reforming our tax code, reshaping our regulatory system, renovating how we fund infrastructure, and taking some initial steps toward a more competitive hospital market. When it comes to healthcare more broadly, however, lawmakers haven't been ambitious enough. For example, bills to empower advanced practice nurses to deliver more services at an affordable cost have repeatedly failed to gain traction in the legislature. As a result, North Carolina is losing some of our best healthcare professionals to a neighboring state, Virginia. So here's where the rub is coming in. That's the finding of a new study conducted by scholars at West Virginia University's NE Regulatory Research Center. They examined the changes in the number of nurse practitioners in North Carolina and its neighboring states from 2016 to 2023. Okay. In most of the country, including states such as Massachusetts, New York, Kansas, and Utah, nurse practitioners are free to deliver medical services for which they're licensed as independent providers, rather than have to be supervised by and surrender part of their incomes to physicians. A second category of states, such as Pennsylvania and Illinois, offer nurse practitioners some freedom but limits their independence or service delivery. It's like Indiana. A third group of states, including North Carolina and its neighbors, have long imposed major restrictions on one or more elements of nursing practice. In 2018, Virginia passed a measure to give nurse practitioners more independence. That set up a, quote, a natural experiment, allowing research to compare nursing populations and health outcomes in contiguous, otherwise comparable states. Here's what they found. Before Virginia's reform, it had significant fewer nurse practitioners per capita than North Carolina did. By 2023, the gap shrank by half. Relative to bordering counties in Virginia, North Carolina interior counties experienced a 20% decline in the number of nurse practitioners per 100,000 residents. They found no such difference when comparing North Carolina counties to bordering counties in Georgia, South Carolina, and Tennessee, none of which enacted major scope of practice reform during the period. That relative decline in nurse practitioners may have led to adverse health consequences. Although the researchers found no significant differences in vaccinations, mammograms, or preventable hospital stays, they did detect an increase in the share of North Carolinians reporting poor health. Previous studies show that this relationship holding in the opposite direction as well, suggesting that increasing the number of nurse practitioners and allowing them to practice independently would improve patient health outcomes. Coupled with our findings, this suggests that North Carolina can improve access to primary care and ultimately improve patient outcomes by allowing nurse practitioners to work in the full stint of their training. So we will see. So there is a debate now about the scope of practice reform. A lot of times, again, it's always, pitting physicians against nurse practitioners on the other side. And other studies confirm the interests of patients are at stake. Expanding access to primary care is clearly a good thing. And predictions of reform opponents were justified that nurses practicing without physician supervision pose a significant risk to patients. There's been evidence for that in the data. This is, again, an opinion piece. So also, I noted that West Virginia University found no such adverse effects after a scope of practice reform in Virginia. Because the government accounts for a large chunk of the medical spending, taxpayers also have a stake in the debate. A 2019 study in the Journal of Nursing Regulation looked specifically at the effects of scope of practice reforms on Medicaid recipients. They found that outpatient costs were 17% lower and prescription costs 11% lower in states where nurses enjoy full practice authority. So this is an opinion piece. Let me know what you think, because we got another story that's coming up after this. But let's think about it, because I think a lot of times we talk about how nurses make an impact on healthcare, and there's plenty of studies that show this. How much better would it be to prevent disease before the person gets there? And I think nurses are naturally very good at that prevention piece. So let me know what you think. Let me know your comments. All right. So here's another story. This is coming out of Nebraska. I told you we got a lot to cover today. We're making up for those times we didn't have as much. This Nebraska nurse gets licenses yanked in connection with weight loss business. This is another cautionary tale, and I'm sharing this because I want us to know what not to do as nurses, as nurse practitioners as well. So this is stuff you don't want to do. So this is from the Nebraska Examiner. It says a Nebraska nurse has had her license revoked for at least 2 years by the state's chief medical officer for alleged fraud related to her business, which advertises weight loss medications on social media, according to the Nebraska Attorney General's office. Andrea Messenger of Weeping Water, an advanced practice registered nurse, has been running a business called AR Virtual Health, which markets medications such as tirzepatide and semaglutide for weight loss. In a settlement agreement filed with the State Department of Health and Human Services, Messenger says she neither admits nor denies allegations by the Attorney General's office, but she consented to the order by Timothy Tismer, Nebraska's chief medical officer, that defines the allegations to be true and that the grounds exist to revoke her licenses. She acknowledged that the revocation of her nursing license is for a minimum of 2 years, and reinstatement is at the discretion of the Department of Health and Human Services and upon approval by the respective state nursing boards. So again, here are my questions and concerns. Nurses, let's not get ourselves into those issues. Find out what you need to do to practice legally so you don't get into these regulatory problems. The order signed by Tismer was in response to a November 5th petition filed by the Attorney General's office to seek disciplinary action to revoke probation and to temporarily suspend Messenger's licenses. The petition alleged that Messenger was practicing the profession fraudulently, beyond authorized scope, or with incompetence or negligence, including obtaining a fee for professional services by fraud, deceit, or misrepresentation. Previously, the Attorney General's office filed petition on May 16th, alleging that Messenger was trying to sell the medication without establishing any patient-provider relationship. So again, part of the problem, I think, what's happening is that this was a telehealth type appointment. She's not actually seeing the patients face to face. That might have been the problem. And it sounds like there was no medical director or somebody for this. She was acting as her own medical director. And I'm not familiar with that particular state's Nurse Practice Act. So if those of you who know, let me know if she should. But according to this, that was part of the issue. So it says, as a result of the lawsuit, Tesmer had ordered a messenger to pay $3,000 civil penalty and place her on probation for a year. Her license was suspended, and she was not to engage in activity that constitutes practice of an APRN of nursing. So according to Tesmer, messenger provided prescriptions to a Georgia patient, although she held no license in Georgia. This is a problem. See, you're doing these telehealth things. You have to make sure that you are licensed in every state. So it would be great if we had a national telehealth license, but we don't. This is how you get into practice issues and problems when you don't understand. Provided care to a patient in Illinois where she holds no license. Held virtual appointments with a Nebraska patient while her license was suspended. Prescribed medications in numerous states with no licensure. Shipped patient medications to her own address or to a coworker or friend, and authorized dozens of prescriptions to Nebraska patients while her license was suspended. So I'm telling you this, hey, don't do those things, okay? You have to take care of your license. Your license is your business, and if you aren't taking care of your license, these are some of the things that can happen, okay? So be very careful about that. All right. Let's take another brief break, and then we're going to go ahead and get on with it. Life support CPR classes. Teachers, do you need to get your CPR requirement completed for your certification renewal? Nursing students, want to get a jump start on preparing for clinicals? Healthcare workers, do you need to renew your certification for your employer? Baxter Professional Services Health Education has what you need. Friends and Family CPR is available for anyone who wants to learn. Register today at Baxter Professional Services HealthEducation.com. All right. Here's our next story. We have another case of potential strike. So this is workerscompensation.com. So if you want to get this information here, do that. But it says Nurses Union says work environment unacceptable due to attacks. This is another case of violence in healthcare. It's coming out of Rhode Island. A nurses union is speaking out about the work environment at a state-run facility after a violent patient repeatedly attacked staff members. The allegations came after a nurse was allegedly attacked on November 15th at the Eleanor Slater Hospital's Zambareno campus. United Nurses and Allied Professionals Local 5019 said its members are extremely frustrated after being attacked and having had a grievance they filed rejected by the Rhode Island Department of Administration last month. UNAP President Lynn Blaise said that the patient was transferred to Zambareno after the state closed another hospital, the Reagan Building, a separate division of Eleanor Slater Hospitals, for renovations. Union officials said after the patient arrived in Burrillville, he started assaulting staff members and hurting himself. In its grievance, the union said the patient acted violently, including throwing feces at a nurse, pulling another nurse's hair, and assaulting two staff members. In one incident, the grievance said the patient left scratches on a nursing assistant's arm that drew blood. Blaise said nurses are told to go into the patient's room prepared to be attacked. He bites, he scratches, he hits, he punches. No one should have to work under those conditions. To tell your staff that you need to be prepared to be attacked and not put the resources in place to prevent those attacks is unacceptable. A spokesman for the RI Department of Behavioral Health, Developmental Disabilities and Hospitals said the safety of our patients and staff in our hospitals is of the utmost priority. The usual, standard line. Edgar said the department has increased the security on the patient's unit and has staff when working with him and retrained its staff on, quote, safe patient handling. So again, blaming the staff. Okay. The hospital considers multiple strategies to enhance the safety of its staff on an ongoing basis. Blaise said these actions weren't enough. The union said it's filed criminal complaints against the patient, as well they should. Talk doesn't get us where we need to go. We need action. The union also requested that the hospital transfer the patient back to the original campus that he came from and even considered discharging him to a homeless shelter. But staff with Eleanor Slater Hospital said the patient's medical needs are too much to handle at any other psychiatric hospital in the state. Blaise said The issue is emblematic of the larger issue of violence against healthcare staff at hospitals across the state. It happens, she said. There's still a lot of work to be done when it comes to ensuring the safety of all our healthcare workers in the state and every hospital. We must face this every single day. Across the country, nurses, doctors, and healthcare workers are under attack. Jones was charged with battery and possession of illicit substances. Doctors Hospital said it has zero tolerance in regard to violence toward its staff and working with law enforcement on the case. In Townsend, Virginia, a California man was arrested after he attacked a nurse. Police in Townsend said they were called to Grace Cottage Hospital on November 20th after the patient attacked a nurse. The nurse was treated for facial injuries and released. Vermont State Police said Adam Roach, 22 of San Diego, had fled the hospital after the attack and damaging property at the hospital. With some help from the public, police said they found Roach and arrested him. He was charged with assault on a protected professional and unlawful mischief. And in Staten Island, New York, a man was charged with assaulting a nurse at Richmond University Medical Center earlier this month. Officials said Alex Xander Lopez of West Brighton was charged with a third-degree assault and second-degree harassment in connection with the November 5th attack. Officers said Lopez punched a female nurse in the face and pulled her hair with both hands as she tried to insert an intravenous injection into him. Violence against healthcare workers is on the rise. Those workers are 5 times more likely to experience workplace violence, according to the U.S. Bureau of Labor Statistics. Attacks on healthcare workers account for 73% of all non-fatal workplace injuries and illnesses due to violence, BLS statistics show. According to a report from the Emergency Nurses Association released this year, more than half of the emergency nurses, or 53%, surveyed in 2023, said they had been attacked or threatened with violence in the past 30 days. So if you want to hear more about this and this important topic, please head on over and share this information. And there's a lot of great organizations that you can work with that are helping to reduce bullying and violence in healthcare. And I'll be happy to share that information with you. Okay. All right. Here's our next story. Nurses Union responds to Albany Med lawsuit. This is from WNYT.com, News Channel 13. Albany Medical Center has filed a lawsuit against the New York State Nurses Association alleging trademark infringement. The lawsuit comes as the nurses union and hospital are in the middle of contract negotiations. So again, this is where sometimes the hospitals are playing fair, right? And they'll do anything to stop the process. The hospital says that its trademark on the titles Albany Med and Albany Medical Center. Albany Medical Center is alleging that the Nurses Association is using the hospital trademarked phrase Albany Med Quality Care as the domain name for the nurses' website. Albany Med executives are attempting to avoid accountability for staffing crisis at the hospital and silence its most vocal patient advocates, the NYSNA nurses. This latest legal maneuver is part of that pattern. Visit AlbanyMedQualityCare.org to see the truth that the hospital leadership is trying to hide. This is from the union statement. If Albany Med is concerned about potential damage to its reputation, it should follow the law instead of flaunting it. We're asking Albany Med to follow the safe staffing law, respect labor law, and stop retaliating against patient advocates. Albany Med should invest in safe patient care, not lawsuits. So we'll see what happens, but they kind of clap back on that one. So we'll see how it plays out in court. I just find the timing of this kind of, interesting since they're going through contract negotiations. Okay. Here's a little bit of good news. This is from Skilled Nursing News, and it says Pennsylvania advances nurse licensure compact, a game changer for healthcare mobility. Pennsylvania is making significant strides in modernizing its nursing license process, enhancing workforce mobility, and improving access to care. With the partial implementation of the Nurse Licensure Compact, or the NLC, and the passage of Act 79 of 2024, the state is setting the stage for full adoption of the NLC in the near future. These developments are poised to benefit the state's 300,000 registered nurses and licensed practical nurses and the communities that they serve. The NLC is an agreement between participating states that allow nurses to hold a single multi-state license, enabling them to practice in any compact state. This framework supports nurses' ability to work across state lines in person and via telehealth, a critical capability in addressing modern healthcare challenges such as workforce shortages and rural healthcare access. Currently, 41 states are full participants in the NLC. Pennsylvania's partial implementation allows nurses from other compact states to practice in the Commonwealth without additional licensure, provided that their primary residence is not in Pennsylvania. Full implementation would allow Pennsylvania nurses to obtain multi-state licenses for practicing in other compact states, is expected in 2025. So please head on over and read more about that. But if you're in Pennsylvania, that's kind of some good news. Particularly if you're working in telehealth and you want to be able to provide those services. I happen to have a nurse that will be coming up shortly in our rotation for our other show, the Nurse Shark Academy show, and she has a telehealth nurse business where she provides the telehealth nursing staffing for the different hospitals and agencies that use telehealth nursing. They provide the staff, they'll pull it off for them. So they don't have to manage their in-house staff. They can actually have a company that does that for them. So I'm very interested, and I want to hear what you have to say when her episode goes live. So look forward to that episode coming up. All right. So this is another story. This is from the Des Moines Register. And this is about strike action. So nurses are going to strike. Said more than 50 nurses turned out in the chilly conditions Tuesday afternoon to show their support for unionizing Unity Point Health nurses in Des Moines. So they are now becoming unionized. As nurses, we are told we are the backbone of this institution. However, we are given little to no power to impact decisions and policy changes that impact our ability to safely care for our patients, steer the health of our workplace, and affect our own personal livelihood, said Cassie Fremel, a registered nurse with Unity Point at Tuesday's rally. The nurses said they intend to form a union over the concerns about compensation, working conditions, and patient care through Teamsters Local 90. If successful, union organizers say that the union would represent 1,550 nurses in Des Moines. I apologize. I mentioned earlier it was a strike. It's not a strike. It's a formation of a union. With more than 600 signatures already in hand, despite the campaign having just started, Erin Carly Olney said she was hopeful of the nurses would be able to vote on unionizing within a month or two. In a statement Tuesday evening, Unity Point Health System Chief Nursing Officer Sarah Brown said hospital officials, quote, understand and deeply empathize with the frustration that some of our nurses are feeling. We acknowledge that recent challenges have left some of them feeling unsupported, and we take full responsibility for that. We are committed to making meaningful changes to address their concerns and improve the experience for all of our nurses. And of course, it says in the article, it may be too late. A Facebook page, United Nurses of Iowa, was created 2 weeks ago and had 804 members by late Tuesday afternoon, including 780 new members in the last week. We're really excited about what the union can do for our patients and our ability to care for the patients better and be the nurses that we envision ourselves to be, said Wendy Armstrong, a union organizer and critical care nurse at Iowa Methodist Medical Center. Unity Point has treated us as if we are disposable labor. Some of the changes that have been made, including shift differentials, have resulted in some nurses getting paid thousands of dollars less while being told by management that the money is not there to increase nursing salaries. But they line their own pockets with money and give themselves bonuses that the total amount that we would make in 1 year's salary. Nurses are left then to make difficult decisions on whether or not they stay at the bedside to protect our patients and support our coworkers, or if they leave the bedside altogether so they can support their families and themselves. Some nurses stay out of guilt over this, and many nurses leave and continue to leave, making the workplace unsafe. Only said the hospitals have the same number of patient beds for fewer nurses and fewer nurses that have been trained to take care of some of the high acuity patients. RNs shouldn't be forced to work under these conditions, and your loved ones don't deserve anything less than excellent care. To add insult to injury, we're told that our patient surveys could be better and that we should do better, and then maybe we would get increased raises. But how are we supposed to have better surveys for our staffing ratios if we're not safe and we cannot properly provide for the patients? On Tuesday at the rally, Tanner Fisher, president and business agent for the Teamsters, reminded nurses that it's illegal for an employer to retaliate or threaten to retaliate against workers forming a union. But as you can see, it doesn't stop them from trying to figure it out how to do it. It may be illegal, but doesn't mean they don't try. Nurses working at the bedsides of 4 Unity Point Health hospitals in Des Moines, Iowa, Methodist Medical Center, Blank Children's Hospital, Methodist West Hospital, and Iowa Lutheran Hospital are in the early days of forming a union in response to their dissatisfaction over patient safety and nurse compensation. So please head on over to read more about this story. Again, I don't have time to go through all of this, but head over to the Des Moines Register if you want to read more about this. I support those nurses and their efforts, and I hope that they are successful in getting what they need for their patients and for their livelihood. All right. Okay. Let's take another brief break because we're going to get into this one. Okay. We're going to get into this one because this is a tough one. All right. All right. This is a story that everybody's been talking about. And I thought I would share it here with you. People have been asking me about. It's from Bloomberg News. And so my initial response is because I'd read their first article. This is a series of articles, and I got to take some issue. But I want to say that the way the article is written, it's really talking about the greed of the hospitals and not necessarily about the nurse practitioners being able to practice. So I want to clarify that because the title is misleading. Okay. But it says, what happens when U.S. hospitals binge on nurse practitioners? Very provocative, clickbaity type, title. And I'm going to call you out on that, Caleb, Melby, and Noah, Bahir, whatever. I'm going to call you out on that one. Okay. Because it is kind of clickbaity. But here we go. So this is our second installment of The Nurse Will See You Now, a series documenting how the increased reliance on ill-trained, and this, it's the choice of your words, gentlemen, I have a problem with. Okay, here we go. Dale Collier had never attended medical school, but as a nurse practitioner, she was empowered to oversee patients that care the same way medical doctors do. She was assigned to the overnight shift at Chippenham Hospital, a facility with more than 460 beds in Richmond, Virginia, where workers say staffing is light and pressure on providers is intense. Okay, so that's the problem. Staffing is light and pressure is intense. Okay, so this is a systems issue. I'm not saying that there weren't problems with this individual nurse practitioner because apparently there was, but in my opinion, she was set up for failure. But let's go on. Chippenham is owned by HCA Healthcare, the $84 billion company that runs America's largest hospital chain. Like a growing number of hospitals across the country, HCA has begun placing NPs in higher stakes roles. For Collier, who had an acute care license, that meant tackling some of Chippenham's sickest patients. It proved too much for her. Virginia regulators later found that patients died after she failed to properly care for them. In January of 2022, a 69-year-old man with rapidly dropping blood pressure suffered what was likely a gastrointestinal bleed after she failed to assess him and order testing. In March of that year, Collier gave an agitated woman 3 doses of a medication that wasn't recommended for a condition, and then another drug until she became unconscious. Collier didn't complete a bedside evaluation or consult a physician. The patient died 2 days later. Less than a decade ago, almost everyone with Collier's responsibilities at Chippenham was a medical doctor rather than a nurse with an advanced degree. At the time of the deaths, MPs like Collier made up a fifth of such staff, one former HCA physician estimated, as the company's hospitals came to operate with some of the nation's most razor-thin staffing levels. So again, it's not that the nurse practitioner, although, like I said, she made some, allegedly, was substantiated, she made some errors. but she's put into a place and set up for failure. When are we going to start blaming the actual problem, right? So, in effect, she was part of an industry experiment at testing whether nurse practitioners can do a physician's job caring for acutely ill patients. Again, this is so inflammatory with the language. The experiment failed. After the deaths, Chippenham supervisor told Virginia investigators that the hospital recognized they had a problem and had fixed it. The hospital no longer hires new graduates onto the night shift. So this is so you hire a brand new grad with no experience as an NP and put her on night shift by herself. And you think this is a good idea. Now, might I suggest that oftentimes they don't let, residents go off. They have somebody that's hired and attending, more experience to be there that they can have her backup. And maybe she had some back. I don't know. But this is the lightest shift, right? The least number of staff. And you're going to put a brand new grad there? Again, set up for failure. Because you want to keep the costs down. I'm talking about you, HCA. But it says further that Virginia regulators say they can't confirm that any such change was implemented. Staff who spoke to Bloomberg Visit Week said it never was at Chippenham or at the scores of other HCA facilities across the country, an assertion the company did not dispute. HCA spokesman Harlow Summerford said the company uses NPs to supplement, not replace, physician-led care teams in hospitals because of a nationwide doctor shortage. He says its use of properly trained and licensed NP is appropriate. They are supervised by physicians who are available for consultation. Far from such an aberration, the circumstances in which Collier was operating are emblematic of a sea change in American hospitals, where the number of NPs with the same and the amount of responsibility they're asked to shoulder is rapidly growing. Business Week previously revealed widespread problems in how nurse practitioners are trained. So that was the previous article. There are issues, and we will own some of that. There are some schools that have come into place that don't have the same strict guidelines. When I was in NP school, there are strict things you had to do. You had to at least have a minimum of a year, if not two, as a registered nurse before you even enter the program. You had to have rigorous training in all your clinical areas. So you were actually training with staff in all your areas. It was intense. You even practiced before you even got to see actual patients. We had a whole class on just doing your clinical assessment with live models. Okay. So you learn all those skills and practice those skills on actual people before you went out to see patients. So it was a lot. Okay. And I don't know if this is the same in all these other programs because I've not attended them. I can just tell you from my experience, it was very intensive. And you had to pass with a B or above because a B minus was a failure. Okay. It was that intense. That's what my graduate experience was. I don't know what some of these other graduate schools are like. So I know that we had a conversation this in nursing about we need to standardize some of those programs. Okay. So I am not arguing against that. And I often would say I would not let a brand new NP be out there by themselves. That's a recipe for disaster. They put them out on the island by themselves. But, let's go on and get into it. So, it said in one reported way, hospitals have little choice. They need providers to handle growing demands for healthcare. Physicians are in short supply, and NPs can fill the gap. There's also financial motivation. A primary care physician costs about $343,308 a year, whereas a primary care NP costs about $1,056 and $546 a year. Healthcare, primary care NPs can generate about $424,000, $425,000 a year in direct revenue, only $37,000 less than a physician. So, in other words, NPs can be seen as twice as profitable, and that is part of the problem. So, you're putting nurse practitioners in unsafe conditions, right? And then using them to get your profit margin, and you're kind of throwing them out to the wolves. And I feel bad for this nurse practitioner. Okay, I feel bad for her for having been in that position in the first place, which I don't think she should have been. Okay, that's you're here there. This is a brand new MP. I know I was not ready to be out there freewheeling and doing whatever, right? So this is coming from someone who's had years of experience and who has I have trained nurse practitioner students as well. So it's not like I haven't taught on that level and precepted many nurse practitioner students. But here's what they're pointing out. And so this is why I say the title is so misleading and so against nurse practitioners. And I don't think this is the right tone that you need to have, sirs. You need to be pointing towards the hospital system that created the issue, not the nurse practitioner, not the individual nurse practitioner. Because a lot of times in new grads, they don't know what they should and shouldn't be doing. Okay. And that's a problem. So it says, HCA reflects the industry at large. It staffs about 37 NPs for every 100 physicians, slightly more than the typical U.S. healthcare system. But NPs who join HCA are at a particular disadvantage. They work in a system so thinly staffed that there's little margin for error. The company has one of the lowest ratios of physicians and advanced practice providers per bed among the 600 U.S. healthcare systems and the federal government tracks. Registered nurses and other staff aren't included in that tally, but other government data that accounts for a wide range of roles also show HCA tends to staff leanly. And that's the issue. And they've actually got accolades from those in the industry. Hey, your staffing is so lean, it's great, right? And I think this all came out of that whole Six Sigma thing where they took manufacturing data, like, okay, how can we cut the cost of manufacturing and we could be lean in the process? They took that and applied it to hospitals. And I remember when this all came about because I was in hospital leadership where they kept talking about Six Sigma and we're going to do lean, we're going to go lean, right? And so you have this where people are not cogs. Every individual is different. And some people may not respond to treatments the same way. So you can't really staff leanly like that and expect to have good outcomes. But unfortunately, it's all driven by money. So, of course, HCA disputes it. You can look at this article in Bloomberg. It's all over LinkedIn, but people were talking about it. So I wanted to bring it up here. And it says some HCA staff said the company is merely going where the data is taken in a future with fewer medical doctors. This trend has been evident for years in primary care. Fewer physicians are pursuing it, and NPs have filled that role for many Americans. HCA staff spoke to Business Week, said that the shift is now underway in other practice settings, and many of them we will get to a point where there will be no physicians left. I don't think that's the case, but we'll see. So there's more to this. I'm not going to read more of this article because it's just downright insulting in a lot of ways for nurse practitioners because they focus on the nurse practitioner in particular, right? Even though they kind of talk about other advanced practice providers like physician associates, they're called now. But they really want to focus on nurse practitioners. It just burns me up the way they try to throw us under the bus. And this happened to be one particular nurse practitioner that was struggling. And I'm not saying that there aren't problems across the board, but I'm saying you can't put this all at the feet of the nurse practitioners. This has to go to what's going on in healthcare as a whole and what's been happening with these for-profit entities. So there. Okay. That's what I have to say about that. All right. So we're going to go ahead and head to our next story because I think we should end on a happier note. I always like to end on a happier note. So let's do that. So there's a couple of things I want to talk about as soon as I get a chance for this to come back up because it's not wanting to come up. So I'll go ahead and take one more break as I try to get this up. Nurses, are you burnt out, frustrated, looking for something new? Are you looking for more? Nurses, are you ready to feel the sun? You will dream big and expand your consciousness as an entrepreneur. Your nursing license is your key to freedom. Join the Nurse Shark Academy at the nursesharkacademy.biz today. Okay, well, I didn't get a chance to get this up. For some reason, my system went down for a second. I was going over these stories, but I do want to share some great big news because we are over our time anyway. So, coming up this Saturday, if you just missed the announcement, we are having our event coming up. Come and enjoy. It doesn't cost anything, but I want people to just take a break and have our holiday de-stress from what's happening in the holidays. It's a virtual guided relaxation session. We're going to talk about how to manage some of those difficult conversations at the dinner table for Christmas. We're going to talk about how to de-stress and strategize for when you're going to enter those stressful situations. And then we're going to decompress by going through a guided meditation session. So if you're interested in that, just head on over to Baxter Professional Services Health Education and sign up for that. Or you can sign up on Eventbrite. It's also on our Eventbrite page, and it's also an event on our Facebook pages, so you can join us there. But sign up so you can get the Zoom information. This is going to be a private Zoom thing, so I'm not going to live stream it because I want you to be able to relax and enjoy without worrying about whether people are seeing whatever. And so we're going to come together and we're going to talk about getting relaxed and going through some meditation techniques that can help you navigate this stressful time. So that's coming up on November the 30th. And also coming up next year, as I'm starting the announcement, we will be having, next month, I should say, our 5-day challenge. And we're going to talk about building your business as a nurse. We're going to talk about getting your 2025 up and running and the things that you need to do. So be on the lookout for that. Promo should be coming out in the beginning of next week for that event. So we'll be working on that for our 5-day challenge. And it's a free challenge. You just sign up, come in. We will be live streaming that event as well, but stay tuned so you can get a hold of us. And it will be going to our YouTube channel as well as to our Nurse Shark Academy Facebook page, and probably also to LinkedIn. So we'll see where I'll be live streaming that. So I'm going to try to live stream all 3 of those. But sign up because if you sign up and register, you have an opportunity then for some of the VIP things that I'm going to do. So there will be a VIP package for those who want it, which I think you should, because hey, but we'll put in things like a workbook that's going to go along with. So if you're looking to start a business or maybe further your career and maybe you're making career changes, you can get the VIP package because then it has the workbook that you can follow along with it. And then for VIPers, I always do a little something special for you. There'll be a live Q&A afterwards that you can participate in as part of that. So you'll get the Zoom information for that. So you get to the private Zoom for those that are VIPers. And then, of course, VIPers get a little special incentives about some of the other things that we're going to bring in because I like to throw in any bonuses that I can that'll be available for VIPers. You'll get special bonuses as well. And so I encourage you to sign up for that event. So just be on the lookout for that next week because the promos will start going out for that next week as we prepare for our challenge. So let's see. Anything else coming up? Oh, yes. As always, if you want to get you're in the area, you need your CPR training, TB training, don't forget to sign up at Baxter Professional Services Health Education.com. I want to thank you for your time. This is going to be the end of our show. Thank you so much. If you're local and you have an event, or maybe you're a nurse and you're having something going on and you want to promote it, let me know. Just leave a comment and I'll be happy to mention it on the show. Thanks a lot and see you next time.